So my name is Erwin. The ones on Teams, can you hear me okay?
Yes, thank you.
Excellent. So I will share my screen in a few minutes. It's unfortunate that the ones here are unable to see it, but we'll try and sort that out very shortly. Okay. So can you let me know if you can see this?
Yes, I can see it, thank you.
Excellent. Thank you very much. Okay, so yes, my name is Erwin. I'm the nurse consultant for diabetes, and I'm the one managing the teams across site. So, and I was asked by Jane to do something about insulin safety, really. Hannah did the session yesterday in Eastbourne, and I was asked to do the one for here. Okay, so let's have a look. Last question to the ones on Teams. Can you see me transitioning the slides? Last.
Yes.
Excellent. Thank you very much. Okay, so for introduction, we just need to have an understanding on how big insulin safety issues are. Okay, so I think there's a lot of audits that were done for looking at insulin errors. So, were you involved when you were students on the Nadia audits? Has anyone here? No, because we tend to rope in medical students to help us with audits. And NADJA is the National Diabetes and Patient Audits. And we do that yearly, or we did that yearly. We haven't done it because of COVID, of course, but prior to that, we've been doing it year on year. And the outcome of that very worrying nationally. Okay, and we will show you the local and the national picture on the slides later when it's out there. So there's 40% of people with type 1 diabetes and 37% of people with type 2 treated with insulin that had insulin error. Okay, so that's how big the problem is. I think 40%, come on, of patients with type 1 in hospital had insulin errors. That is quite appalling, isn't it? Because if I'm the type 1 patient, so I'm likely to have a medication error, insulin error. So, and the problem with the errors with insulin, if you're type 1, is the acute complications of that. So, if you're type 1 and they miss your insulin, for example, what will happen to you? If you're type 1 and they miss your basal insulin? Hmm? Hyperglycemia, if you're lucky. If you're unlucky, you're going to have DKA. And that is a never event, really, hospital induced DKA. Just because the doctors, for example, amazing doctors, by the way, did not prescribe the insulin because they were busy doing something else. They didn't realize that the Lantus is not prescribed. So, me being the lowly nurse, didn't see the insulin being prescribed. I won't give it if it's not prescribed, will I? So, again, and the patient is not well enough to say that I'm due my Lantus now. Okay, so everything fell apart. The patient at 2 o'clock in the morning is in DKA. So you're gonna have to manage that even more with complexity rather than just prescribe the Lantus, give the Lantus, and everything is lovely. Okay, so those are happening, and 37% of type 2 as well had insulin errors. That is a lot, isn't it? So 6% of insulin infusions were inappropriate as well. So, how many times have you prescribed, not you particularly, have you seen intravenous insulin prescribed inappropriately? Somebody who has high blood sugar and pH is 7.35, for example, but there's ketones, say 2.2 ketones, and you prescribe DKA protocol. So, this is happening. I'm not saying you, as I said, as a you, but this is happening in hospital. So they put patients on a DKA protocol when in fact they're not on DKA in DKA at all. So there's a lot of implications to that because if I'm the patient, I'll have my blood glucose monitored every hour when in fact it may not have been necessary for that to happen in the first place. I will have to stay 2 days to 3 days because I was on intravenous infusion, when in fact I could have been discharged the next day or a few hours later if they managed me more appropriately. So patients with for surgery as well are getting sometimes mixed or wrong prescription for intravenous insulin. They get the DKA protocol. In fact, they should be having the nil by mouth protocol, so, or vice versa. So DK is managed with a nil by mouth protocol rather than the proper DK protocol. So there's a lot of errors in terms of insulin infusions as well. And 25 people yeah, with type 1 diabetes experience DKA, which is hospital acquired. So that is one too many, isn't it? So that is a lot of patients. And one in five person in the hospital has diabetes. So if you can imagine that, that's a lot, isn't it? So that's 20% almost of inpatient has diabetes. So it is a big issue. Okay, so this is the local picture for Eastbourne and Conquest. So on the National Diabetes Audit, insulin errors, they're improving year on year. But in 2019, it's still 27% errors, insulin errors in Eastbourne. And there's about 15% of insulin errors in Hastings. So there's still a lot of insulin errors happening. As I think it's slightly better in Hastings in comparison to the national picture because the national average is 18%. 15% is better, but 15% is still a lot, isn't it? So the next one is an example of a recent error. Okay, so for those on Teams, you can see this hopefully quite clearly. So there's insulin that's prescribed. It says insulin soluble, and it says 8U. So on the prescription, TDS. Okay, so the problem with this prescription, I don't think you can appreciate it, but it's written as 8U. Okay, so it was misinterpreted as 80 to begin with. And I think soluble. I think what does that mean? Insulin soluble. So is that a prescription for insulin? Insulin soluble. Okay, so this is an actual prescription as well. So I think an example I always use when I teach is one of the doctors here a long time ago prescribed insulin. Okay, and I'm thinking, what insulin do you want us to give? Okay, and unfortunately it was given 6 units was given, so that made it even worse because if insulin was prescribed with no name, brand name or anything, and somebody gave it, then that's a bigger problem, isn't it? So so it's this is just I think I'm not making fun of the situation. This is very serious, but these are happening. Okay, insulin soluble, come on, what is that? Okay, and units, it should be written in full as well. Okay, so we made it simple before that we pre-printed units already on the prescription chart, so you don't have to worry about writing new. Now that we're going on EPMA, of course, it's even better because we can potentially prevent more errors because it's going to be electronic prescribing rather than paper prescribing. Okay, so but before, writing you always has this connotation of you should never ever do that. Okay, because you is always being misconstrued as a zero. If the dose is 8 and they wrote 8U and it was given as 80 units, then that is a never event again. That is an overdose of insulin. Okay, so we need to be very careful about that. Okay, so the other one is Lantus 100 units, for example. That's the other example. So what would you do I think it's more if if it's more for the nurses really. If we see a prescription of 100 units of insulin, we need to query that. So is it really 100? Okay, so because before I administer 100, I need to make sure that I'm giving the right dose. It might be 10, and what's your name? And Talia prescribe 10U, and I thought it's 100, isn't it? So I'm not saying that you will, by the way. So, but again, we need to confirm that any dose over 50 ideally should be confirmed. Okay, should be double checked because otherwise it might be 100 accurately, but it might have been prescribed wrongly. So it's better to double check that. But if you're clerking a patient and the patient said I'm on 100 units of insulin or 120, etc., make sure that you write it very clearly as well. Okay, but as I said, EPMA hopefully will reduce most of these errors because it's going to be better. A system will be better to prevent this from happening. Okay, Datix report, there's plenty. So I'm conscious of time, but there's plenty of Datix reports that Jane, I think, helped pulled. So thank you very much, Jane. So there's a lot of prescribing errors, as you could imagine, but there's a lot of administration errors as well and failure to administer. because that is an error still. Sometimes nurses tend to not give the insulin, for example, because maybe the doctor said no, the blood sugar is 4.2. Don't give the Novorapid. Okay, the patient will go too low later. So there's always this fear that if you give insulin, the patient will hypo. When in fact, if the patient is eating and drinking, give the insulin because the patient is a hypo anyway. And even if the patient is hypo, always remember that you need to manage the hypo, let the patient eat, and you still have to give the insulin anyway. Otherwise, you're gonna see rebounds. You're gonna see what do you think will happen if my blood sugar is 3.9 before lunch and I'm due 10 units of Novorapid, for example, and I'm eating and drinking. So if you don't give me my 10 units of insulin after I've eaten, what do you think my blood sugar will be later? It's gonna be high, isn't it? So the way to do that is to make sure that the hypo is managed, the patient eat, and the 10 units is given. Otherwise, the patient's blood sugar later will be 18, and the nurses will come to you and say, Talia, this patient's blood sugar is 18, is 20. What shall we do? Oh, give them 2 units of Actrapid, okay, or something like that. And the problem with that is it's gonna go low later. So you're actually not correcting the problem, you're adding more to it. So as much as possible, try not to. Okay. So being reactive is an easy response, isn't it? If you see a problem, you react. It's normal response. But with insulin, unfortunately, if you react like that, you're gonna cause more problems rather than solve it. Okay. So there's a lot of Datix reports on insulin errors, and unfortunately, they're getting more and more over time. Hopefully, with EPMA again. So I'm promoting EPMA, you see. So I'm a fan of EPMA. So hopefully, with that, we can reduce the incidence of errors. Okay. So common reasons for the administration dose, it's likely the prescription, of course. Okay. So and the abbreviation of units again. So hopefully this won't happen again. Poor documentation of dose, errors in calculation of insulin doses for IV infusions. These are common themes for errors. Individual doses, the individual rather does not know how much they should be taking. So this is a common problem for you, isn't it? So if you're clerking the patient and they have diabetes and they're on insulin, they'll say, I'm on a green pen and an orange pen. I don't know what they're called. Okay. And you said, okay, fine. So that's Levemir, which is the only green pen available, and the Novorapid, which is the orange pen. That's fine. But the problem is, I don't know how much I take. So again, there's an issue there, isn't there? So what is the initial response you will make? You won't prescribe a dose, will you? Because you don't know the dose, you don't prescribe it. So that in itself is an omission because the patient won't get the insulin if it's not prescribed in the first place. So I think you need to make sure that you do your detective skills. You use them very well and look on the e-searcher or whatever platform is available and look at the history and see what you can find, or maybe phone the family. Find something, do something to make sure you can confirm the dose if the patient is unable to provide that information. But failing to do that, I think you need to maybe have an understanding of how can I start something anyway? How can I extrapolate a dose so that I can start this patient safely until I can be sure of how much the patient's dose is actually, or doses are actually taking. Okay. Do you know how to do that? Do you know how to calculate, maybe how to calculate doses? Has that been taught before? Do you know what to do? If you know the total daily dose, isn't it? The problem is the issue is the patient is on Novorapid and Levemir or Lantus or whatever, and the patient doesn't know how much they're taking. Do you know how much? Do you know what to do to extrapolate the dose to begin with? And then you can use their weight as an example. Okay, so how do you use the weight? Well done. Okay, so for those who can't hear, because they may not have heard you, so I think Talia mentioned the zero point 0.5 units per kilogram body weight if they're non-renal, whereas if they're renal, you can use zero point 0.3. and use that information as a starting point. Okay, so that's the total dose though. If they're on basal bolus like Lantus and Novorapid, then you can give half of that, 50% calculation, as a basal or lantus, and the remaining half divided into 3 meals. Okay, so if the weight is 80, the total dose is 40, the lantus is 20, and the novorapid is 686. Make sense? So it's easy to extrapolate, isn't it? So if you don't have that information, but so if you do have that information, of course, it's better to confirm. And once you confirm, prescribe, because if it's not prescribed, it won't be given. Remember that. And the errors on of omission is there because there's an error in prescription. Okay, so duplicate dose administration. I think this is more, of course, the person administering the insulin. Sometimes the patient is self-administering, and the nurses didn't bother to ask, "Have you given your Novorapid?" And the patient just having a patient role just sat there. Yes, give it to me. Okay, so when in fact the patient had it already. So those issues, of course, it's important that you clarify, you confirm before you act. Okay, and for the infusion is more incorrect programming of electronic devices. Okay, because sometimes the patients are requiring 1 unit of insulin per hour intravenously, for example, equivalent. Then they may have programmed that to 10 units per hour instead. Okay, so those are errors that are common in the administration of the dose. What we have been pushing is the 6 R's to insulin safety. Okay, so locally, we've done this, and then with Jane's recommendation, actually, we did this pilot, and then this became national. So if you work in other trusts before, we have the Insulin Safety Week that is happening every year. So we are the pilot for that, and then the year later it became national. Okay, and we have been pushing for the six R's of insulin. We have the right person, right insulin, right dose, right device, right route, and right time. So I'll just go very briefly individually what the R's are. So the first one is the right person. Make sure that it's the right patient. Okay, if you prescribe insulin on A1, make sure that A1 is the person with diabetes. Okay, not A2 who doesn't have diabetes. So again, make sure that the prescription is the right person. And I think it's important to individualize care, of course. So if you're going to start treatment on anyone, make sure that you assess their ability to manage that treatment. Otherwise, what's the point? If you start someone on 4 injections a day and they're blind, or for example, they can't inject their own insulin. So you need to be very careful when making assessments like that. So you need to make sure that you assess their lifestyle, for example, their eating patterns before you look at insulin treatment. But the right person really, in terms of insulin safety, is the last R for me, because I need to make sure everything is correct and I give it to the right person. Make sense? Okay. Because otherwise, to be honest with you, I think if one of them is wrong, everything is falling apart anyway. But I always say the right person at my presentation. Okay. So the next one is right person. Okay, so right insulin. There's a lot of insulin available. I think if you're going to use EPMA, which I hope some of you are starting to use already, for those working in the hospital, then you'll see when you look at insulins, there's a lot of them on the drop down options. Okay, so there are 30 different preparations, and there's a few strengths as well available now, which I think it was a standard 100 units per ml before, but because patients tend to require more and more insulin, so they especially the ones with type 2 diabetes who are insulin resistant, they launch higher strength insulin. We have U200 now, or 200 units per ml, and we have 300 units per ml. And unlicensed, we have 500 units per ml, so 5 times stronger than the usual preparation. I will talk to you about what they are later on. And but The important thing is never draw out insulin from a pre-filled pen or cartridge. I think this is not something you'll do anyway, because you are more the prescriber. You prescribe it. I think for the ones administering, it's important that we do not draw it out rather from a pre-filled pen or cartridge, because that's not. advisable. Okay, especially as insulins now, as I said, we have higher strength insulin, because if I'm gonna drop insulin from a 200 units per ml pen, for example, if I drop 10 units, that's 20 units equivalent. Does that make sense? Because of the concentration. Yeah. So hence, we never advise drawing out insulin from a pre-filled pen or cartridge for that matter. You always have to prescribe by brand if you could, because I think one good example is Glargine, for example. You know, Glargine is Lantus, yeah? So if you prescribe Glargine, you could potentially be given Lantus, you could be given Semglee even, which is a biosimilar, because Semglee is Lantus, is Glargine rather, and Toujeo, which is 300 units per ml, is Glargine. So if you prescribe Glargine, then you have a few things there that the pharmacist may dispense if they're not careful. Okay, so you need to make sure you prescribe by brand. So if it's Lantus, for example, that's Glargine, but you have to prescribe Lantus rather than Glargine. So if you, what other examples can you think of? Because that is the main example we normally use, you see, because most of them, there's only one of them. Okay, like Novorapid, for example, there's only one Novorapid. Okay, so there's no other Novorapid, but Glargine, as I said, there's about three or four Glargines available now. Okay, so make sure that you prescribe by brand. Okay, it's Novorapid, it's Levemir, it's Tresiba, it's what else? Apidra. So those are the insulins. Humalog. So don't prescribe the other. Okay. Let's have a look. The next one. If you have any question, by the way, you can stop me at any time. Okay. So in terms of the insulin strength, so we have 200 units per ml Humalog, for example. So do you see what I mean? So Humalog is available in 100 units per ml and 200 units per ml. And Tresiba, which is Degludec, is available in 100 and 200 as well. Okay. We have Toujeo, which is Glargine, as I said, is available only on 300 units per ml. And the unlicensed Humulin R is available in 500 units per ml. So we have different concentrations of insulin. What is important to note is that the highest strength insulins are available only in disposable pen devices, because the pen is calibrated to give half the volume or a third of the volume, depending on the strength. So if the patient is having 100 units per ml normally, for example, and they're prescribed 50 units of, say, Tresiba, if they're using 100 units per ml, you dial 50, you get about zero point 0.5 mil volume. So if you're using 200 units per ml, you might get half of that volume at the same dose. Make sense? Okay. What is important in terms of administration, just in case you have to administer insulin using higher strength devices, is the dose you dial is the dose you give. Always remember that. Okay. Because patients tend to think, oh, this is twice as strong. If you explain to the patient, this is twice as strong, and you're on 50 units, they'll say, if it's twice as strong, I'll give 25. Okay. Because that's 50. It doesn't work like that. Okay. So if you're on 50 units, you dial 50, you're just giving half the volume. Make sense? Okay, so I think it's important that staff understands that as well. Okay, so those are the highest strength, higher strength insulin. Biosimilar is out now, so I think Assembly is one, because I think Glargine is what's the term? It's off patent. It's off patent now. So the molecule has been bought by different companies. I think Pfizer is manufacturing Glargine as well. Other companies are manufacturing Glargine, and they're calling it something else because it's the mother molecule. So it's the same. It's a biological copy. Okay, so it's not identical, but it's a biological copy. So the action is the same, but it can be cheaper. You see, and with the pressure financially in the NHS right now, I think there's of course pressure to use more cost-effective products. So it doesn't mean it's less effective, but that's why it emphasizes the importance of prescribing by brand rather than. Okay, so if you want Semglee, you need to prescribe Semglee. You don't prescribe Glargine. That's the point to that. Yeah. If you're a clinician, is applicable in primary care, and you want to change Lantus to biosimilar, then you need to make sure that you consider that there may need to be a dose adjustment. So it may not be like for like. Okay, you might need to reduce it or maybe increase it. So depending on the patient. Okay, and make sure that you consider all of those factors. Yeah. Let's have a look. In terms of insulin action profiles, there's different types of insulins. We have rapid acting, short acting. So those are completely different insulins, by the way. So we have intermediate acting, we have long acting, and we have biphasic insulin or mixed insulin. Yeah. So there's a lot of insulins out there. And this slide, which unfortunately you can't see, clearly. This slide illustrates the different action profile of insulin. So I think you might find this useful when you actually have a copy when it's sent to you. Yeah. Short acting are humans. Always remember that. So short acting human insulin, because the analogs are the rapid acting insulin. So the example is for short acting is Actrapid. Actrapid or Humulin S is another. Okay, so these are short-acting human insulin. So we don't use them as much because the problem with them is their profile. Okay, so their action profile is, although they're called short-acting, they don't really act that short. Okay, so I think there's a few slides later. Actually, there may not be, so I'll talk about them now. So if you inject Actrapid now, for example, it will work after half an hour, 45 minutes, and then it will peak after about 4, 5, 6 hours, and then it's gonna leave the system about say 12 hours if you're lucky. Okay, so they're not really that short acting, are they? Okay, whereas Novorapid is in and out, so it works after about 5 to 10 minutes. 15 minutes max. It peaks after 2. It's gone in 4. Okay, so a good point to talk about when we're talking rapid acting is if you're going to prescribe a stat dose of insulin for a patient's blood sugar, if they're high, then I would rather you don't prescribe Actrapid at all. Okay, because I still see that in A&E actually. I still see that in the ward sometimes that some doctors prescribe Actrapid. Okay, PRN. Okay, and I think they use 6 units for some reason. I don't know where 6 units come from, but they write 6 units. Okay, and that's something that we never encourage. PRN insulin is not something we would encourage. I always tell doctors when I teach them that if you write Actrapid PRN, don't waste your ink, because if I see that, I'll just cross it off. Okay, don't waste your breath, really. Don't waste your effort. So the reason for that, as I said, is because it lasts a long time. Okay, so if you want something to solve that high blood sugar now, you use Novorapid or a Pedra or Humalog. Unfortunately, in the trust, we have supplies of Novorapid easy, so I think just use Novorapid, okay? And the staff are well aware and familiar with Novorapid. So if you want to correct a high blood sugar, then use Novorapid instead, okay? And prescribe it as stat, not as a PRN, because that is a prescribing error again, because sometimes or most of the time, if you write on PRN, you write the dose and the insulin, and you don't put the maximum frequency. So that's always left blank. And if I'm the nurse administering the insulin, I might give that every hour, because you write there that it's 6 hourly, for example. So, oh, it's high again. So 2 hours later, I'll give more. Okay. Oh, it's still high. I check 2 hours later, it's still more, it's still high. I'll give again. So, and the patient is on the floor having a fit with a hypo severely by morning. So you need to be very careful about that. And again, this hopefully is something that EPMA can help address, because that there will be some I think some pop-ups or something to help with that. I hope, Jane. I'm not just making that up. So there's some alerts anyway, if you're prescribing, and which is very good, isn't it? So, but even if you move to a different area, I would rather that you don't use Actrapid, because this is a national thing now. It's not just us. Okay, so if you want to improve blood glucose very quickly, prescribe stat and use Novorapid or something rapid acting, not short acting. Okay, is that okay? That's fine. Okay, so that's the Act Rapid question. So Act Rapid has a place in treatment. Don't get me wrong. When do you use Act Rapid? You use Actrapid in intravenous insulin. Okay, you don't use analogs in intravenous insulin. So if you have a patient that requires intravenous insulin infusion, the insulin use is still Actrapid. So there's still a use for Actrapid, but don't use it subcutaneously, especially for correction. Okay, so let's have a look. Okay, short-acting humans. There you go. That's the slide. So that's the profile of action. So that's actually not as a good representation because it lasts longer than that. Okay, it sometimes it lasts up to 8 to 12 hours. Okay, and the peak is quite prolonged as well. So it's not like it's like that. The peak can last a few hours, which is worrying because when insulin peaks, always remember that's when it's most effective, isn't it? So the hypo risk is higher during that peak. So if you're using human insulin, the peak is longer, the risk of hypo is longer. So we want to minimize and reduce the risk as much as possible. So we have rapid acting insulin. Of course, these are the analogs. We have Novorapid, Apidra, and we have Humalog. So they're in after about 5 to 10 minutes, 15 minutes max, and they peak after 1 to 2 hours. They're gone in four, so they're in and out. Okay, but we also now have insulins called ultra. Rapid acting. So this is where a Fiasp is a good example, and I think there's another one called Liumjev, which is out recently. So this is a Humalog equivalent. Okay, so this works after 5 minutes. Okay, so they can be given immediately before food or immediately after even, or can be even given 5 to 10 minutes after the patient has eaten. So there's more flexibility with the timing, just in case the patient's appetite is poor, then at least you can eat and then give the insulin later. So you don't have to give the insulin now and then eat less, you're going to hypo afterwards. Does that make sense? So because if you give the insulin now and you didn't eat the food you should be eating, the hypo will happen later on. So with this type of insulin, because you can give it after, you can gauge how much you've eaten before you give the dose that is corresponding to the food you've eaten. Yeah, so there's more flexibility with timing. And then we have intermediate acting insulin, we have insulatard, Humulin I, and we have insuman basal, which I don't think you should yeah, you should worry because that's not on the formulary anyway. We normally use insulatard and Humulin I. Okay, so and these are the old long-acting insulin. So again, the problem with them is they peak, and the peak is very long. Okay, they last about 18 to 24 hours, but they peak for about 6 to 10 hours. So that risk of hypo is very prolonged with this insulin. And then we have the long-acting analogs. We have Levemir and Lantus. So those are the most common and conventional analog basal. But we now also have ultra long-acting insulin. We have Tresiba or Degludec, and we have Toujeo. And Tresiba lasts for 42 hours, whereas Toujeo lasts for about 36 hours. But don't be fooled by the duration of action because they should still be given at the same time roughly every day, even if they're given even if they last that long. I mean, is that right? So if they're given in the morning at 8, they should be given roughly the same time every morning. Yeah. Okay. So there's no over what do you call it? There's no stacking effect because of the sophisticated release of the molecules. So you're gonna reach a steady state after about 5 days. So there's no stacking. Yeah. So they should be given at the same time every day or every evening, whatever time the patient chooses. Premix insulin, we have humans. Human insulin, we have Humulin M3 is the most common. And we have insulin combination, 25 or 50 or 10. And for the analog mix, we have Novomix 30 or Humalog Mix 25 or Humalog Mix 50. Again, so you have to be very careful with the names of the insulin because unfortunately, when they named the insulin, they were not very creative with them, especially Lilly insulins. They're all called Humulins. So how poor is that? That's you all call your product Humulins because you can prescribe Humulin M3, Humulin S, Humulin I. It's easy, isn't it? If it's a drop down, you tend to, if you're busy, just pick the first one. So if you want Humulin S and the first one is Humulin I, then there's an error potentially waiting to happen. So I can't help with that, unfortunately. So, and they can't change their names either because it's apparently very costly to change the name of a product. But same thing with Humalog. They're all called Humalog and Humalog mixes. So again, that's another issue. Okay. But with EPMA, you can, as I said, when you use electronic prescribing, you can see all of them. Okay. And the good thing about the EPMA is that it tells you, it gives you an image as well of how it looks like. So at least you have an idea. Okay. If it's a vial you're prescribing, for example, oh, I don't need that. If it's a cartridge, I don't need the cartridge. It's a pen I want. So you need to just then pick until you find it. So when you find it and there's a visual representation, I think it lessens the error potentially, doesn't it? So because if you want, for example, a pen and you see this, you click on that, then you're on the wrong one, aren't you? Okay, so it's nice, really, to have that. So all the templates have pictures on them. Yeah, the right dose. So it depends on the individual, of course. Okay, so never use abbreviations. That's another repetition of my advice a while ago. And ensure the prescription is signed and dated. So this is a common prescription error again. It's more that some of the medics don't sign insulin for some reason. I don't know why. I don't know why you forget to sign your insulins. Okay, so every time I go to the wards, there's not all the time. There's one that the dose are prescribed, the insulin is there, everything is amazing, and then I look at who prescribed it. There's nothing there. Okay, so I have to chase the doctors. Can you please sign this? And most of you denies I didn't prescribe that. Why should I sign it? Okay, so but hopefully with EPMA that's gonna be resolved. Okay, which I'm very excited about. So split dose over 50. So this is an administration issue. So I'm not gonna dwell on that because you don't administer insulin. This is more for the nurses administering it. Okay, but I mentioned that a while ago already. Any doses over 50, you should think twice before you give it, and you should split it if it's administered because that's too big a dose for one injection. All right. So unless they're using higher dose insulin. Okay. So the calculations of insulin we talked about already. I think Talia mentioned that. So a 50 percent or zero point 0.5 units per kilogram. Yeah, for non-renal and a zero point 0.3 for renal. If it's a basal alone, you can use zero point 0.2 units. Okay. For example, the patient is type 2. They're on metformin and orals, other orals, and you think this patient needs a long-acting insulin at least because fasting is horrendous. It's high already. I'm going to start this patient on Lantus in the evening. Okay, so you can use zero point 0.2 units per kilogram as calculation. So if the weight is 80, the dose of Lantus is zero point 0.2 units per kilogram. The weight is 80. Again, so if my weight is 80 kilograms and they're using zero point 0.2 units per kilogram body weight, so how much Lantus would you start me on? The one on Teams. I hope you're still awake. Exactly. There's going to be 16 units of insulin, Lantus, prescribed at bedtime. Okay, so that's a starting point, isn't it? So they're easier to remember. So zero point 0.5 for total daily dose and zero point 0.2 for basal alone. Okay, and the presentations will give you that. And start doses, as I said, clinically needed. If it is, what insulin should you give if it's a start dose of insulin? Novo Rapid. Don't give Actrapid. All right. So never use Actrapid. Only use Actrapid for intravenous insulin. Or if a patient is on Actrapid when they come in to the hospital because they don't want to change to analogs. Yeah. Okay. So let's have a look. EPMA, again, this, I think you had sessions on EPMA anyway. You had training on EPMA. You have to do the online thing. You've done that already, all of you, yeah? So there's, of course, elements of that related to insulin. And a few examples of prescription discharge here. Okay, so some patients were discharged with insulin Levemir, 128 units, for example. So I think that's something that you just need to clarify. Okay, if you think, oh, 128, so maybe the patient's dose is not 128. And for this particular person, see you later, it turned out that this patient is only on 28 units and they wrote 128 on the discharge summary. So we need to be very careful about that. So right device, as I said, you don't need to worry about this because you won't be looking at devices anyway. Okay, but there's multiple devices available for insulin. So right route is either subcut or intravenous insulin. So for injection technique, I'm not even gonna dwell on that because, as I said, you're not injecting insulin as such. Okay, but I think I need to emphasize for the intravenous insulin administration, you have different protocols available in the trust. You have a DKA protocol, which is the orange sheet, okay, and that's the HHS as well. And we have the green, which is the nil by mouth, the yellow, which is the ACS, and we have the purplish colors for antenatal labor, delivery, and steroids for antenatal only. Okay, so we have different regimens there, and with EPMA, unfortunately, you still have to use the paper documents. I don't think they have linked successfully the actual form online. Okay, so it will then advise you that please see paper or use paper a copy or something to that effect. All right. Like so, please see paper. There you go. So for the intravenous insulin, hopefully when the EPMA develops over time, we can then start looking at intravenous insulin electronically. But for now, not yet. So right time, I don't think this is going to be too relevant for you as well because most of these are administration issues, you see. So the nurses should be the one making sure that the timing is correct because if they're rapid acting insulin or mixed insulin, they should be given with food. That's the thing, isn't it? So in terms of the prescribing element for that, so if it's rapid acting insulin, don't prescribe it at bedtime because this I see as well as an error. Okay, Novorapid is prescribed at bedtime, or Novamix 30 is prescribed 8 o'clock and 2000. That's wrong. It should be 8 o'clock in the morning and 1600 or 1800 rather, 6 p.m. In the evening. All right, because otherwise it will be given without food. Hypo will happen. So make sure the timing is correct in relevance to prescription. Yep. I am. So I think I would like to just it's almost done actually. I would like to finish off by saying that we have resources available that are linked to this presentation, and I would suggest that if you have clarifications or maybe if you feel actually a session on intravenous insulin management might be relevant, so can we have that separately? So the diabetes team is more than happy to provide that for you. Okay, just let us know. And there's a lot of links, as I said, on safe use of insulin available online. Okay, so I think I need to end it there because I'm conscious that with the session starting late. I do apologize to the ones on Teams if it was very rushed, but unfortunately we all have commitments after 4, and I bet you're all raring to go. So, do you have any questions, just in case? No? Any questions from the ones if they're still there on Teams? I think they're all gone, aren't they? So, so that's fine. In that case, if there's none, then thank you very much. And can you let me know